Good afternoon, everybody. Thank you very much for joining us here today. We are going to be going over interoperability and the truth behind the MIPS curtain. Our presentation today is going to be by Lauren Patrick, the CEO of HealthMonics, Lou Galterio, the CEO of Suncoast Rio, and Dan Hogan, a healthcare consultant. One thing before I hand it over to Lauren is we have here the ability for you to ask questions. If there is time at the end, I will get to the questions to the panelists. And as well as I added a couple handouts for you, including the slide presentation, if you want to follow along outside of the system. And so without further ado, I'm going to hand it over to Lauren and the panelists. Thank you.
Hi, folks. My name is Lauren Patrick. As Mike already said, I'm the founder and CEO of HealthMonics. At HealthMonics, we are very much focused on MIPS, the QPP, ACOs, and that's sort of where we've been heads down. What we've done today is we've invited Dan and Lou to talk with us because they very much more see the bigger picture. And so we want to talk about interoperability from the standpoint of how does MIPS interoperate with other programs. So I'll turn it over to Lou and Dan so they can introduce themselves.
Okay, thank you. Hello, everybody. My name is Lou Galterio, and I am the founder of the Suncoast Rio, which stands for Regional Health Information Organization. So as you know, in our field, we're full of acronyms here. So my background is engineering, and before I got involved with healthcare, I was working in the banking industry. I was one of the founders of Depository Trust Clearing Corporation, which is a bond clearing company, and they do quite a few transactions per day. I entered into healthcare as the first CIO of Health and Hospitals Corporation in New York City. Back in 1990 around, and started Suncoast Rio when I came to Florida as a nonprofit and with the goal of helping providers know what was about to hit them in Florida, being through it in New York myself. And then after a while, we became a for-profit, and we are now a vendor, and we're a QPP registry, just like HealthMonics, only a lot smaller. And we do get into some of the other aspects of it, and I'll talk about those as we move forward. Dan?
Thanks, Lou. Well, good Earth Day afternoon, everyone. My name's Dan Hogan, and I started with Ernst & Ernst back in the 70s in banking and healthcare, and then went into operations in healthcare in the early 1980s and been a CFO since then. So hopefully I can impart some of my experience over the years as we go through our subject matter today that I know all of you are struggling with, and if you're new into this kind of arena, there's just a lot of things to look at. So hopefully we can help you with that.
Okay.
So our goal today is really to cover how MIPS fits into the bigger landscape, to provide an overview of all of the various CMS programs, how they fit together, and how those changes affect not only MIPS, but the bigger picture. We'll talk about how all facilities are involved in this. It's not just your Part B claims, but it's across the spectrum of healthcare, including telehealth and all the various locations where healthcare occurs. Our goal in particular is, like I said, we really focus on MIPS within the HealthMonics world, and really we want to learn from those involved in hospital programs because they've been impacted by a lot of the ideas and regulations that are coming into MIPS and can share with us some sage advice.
Okay. So with that, I'm sorry, you still, Lauren? You ready for me yet?
Go for it.
Okay. So as I said, when Suncoast Rio started, we didn't just start with the Part B, in those days, pay for performance, which became PQRS and now is MIPS, but MIPS is a lot bigger. But back in those days, we had hospital clients, we had all the different clinics, we had payers. So the thing about Suncoast Rio is, don't forget, since we started as a nonprofit, and that's how I met Dan, actually. He was the CFO of one of my first clients. He was actually my second client. But since we started as a nonprofit, I think looking back, one of the things that we gained that I would have never anticipated was we gained the trust of a lot of the decision makers in hospitals, because they didn't look at us as you're telling us this because you want to get a deal or something. We were there. I was there. They actually had me in a lot of their meetings with vendors to advise them, because I had the ability of seeing the whole landscape, and not just a little piece, where a vendor would come in with a little piece, another little piece. And I think, Dan, I think one of the things Dan liked about me, and I'm putting words in your mouth, maybe you don't like me, but one of the things I think Dan liked about me was that I could sit down with him, and I could speak if he spoke about billing, if he spoke about coding, if he spoke about the admitting, if he spoke about the care, doctors. I was able to jump around, because in my job as CIO at Health and Hospitals, my old boss who taught me everything actually had me going on rounds with doctors. So the ability to be trusted and to speak about the whole picture, I think has helped me a lot. Our first real project with a government program was really what is called ESMD, Electronic Submission of Medical Data. And that was way back when hospitals were going through the RAC program and they were getting audited. I don't think we have many hospitals on the line, but if you were a hospital, they're starting to send these letters to Part B providers too, and practices. But in those days, if you were a hospital, they called it a RAC attack. You would basically, CMS hired contractors, auditors, to go back 5 years and look at claims to see if there was anything wrong, and actually take the money back if it couldn't be proven. So our job as a connectivity vendor was the ability to take that data that the auditor was asking for and send it to CMS or the auditors. And we had to go through a lot of certification. It took about a year. And so we're one of 15 companies that CMS accepts data from. And that sort of started us there. And that also started me seeing the bigger picture. So what I'm talking about with that, and then we're talking about the trust fund up on top too. And I want to make sure I don't leave out a big piece about what the trust fund theme is here. The Medicare trust fund, those of you who know that Social Security, people my age had money taken out of our working life, and then at the end, that Social Security would pay you back in your Social Security payments that you get when you're over 65, and also pay for Medicare. Now, those are trust funds, and over the years, they've been very quickly being depleted. And the last estimate for the Medicare trust fund is that it will be insolvent by 2026. Now, I don't want to scare people. Insolvent doesn't mean it's going to go away. Insolvent means that they're going to have to make some cuts somewhere in order to continue paying. The hospitals will probably be the first ones hit, and then the doctors as well. So why am I saying all this is that as the money within the Medicare system gets smaller and smaller, Medicare is focusing more on compliance and audit, because the money to just run all these systems is getting less. So I'm talking about that because if you look at the big picture, the money's going down, the people in government. CMS is just one agency in Health and Human Services. There's also ONC, which Office of National Coordinator, and they are the ones who test the electronic health records, and they're the ones who determine what those EHRs are supposed to do. And the MIPS program comes out of CMS, but now they're starting to mix it with other programs. So you may have heard of the 21st Century Cures Act, which is a collaborative rule from ONC and CMS, where hospitals have to, for every patient that goes in, the admitting, discharge, or transfer of that hospital has to be communicated to the primary care provider. This is a very difficult thing. So how does this affect, again, a lot of people on this call are not hospitals, so you're providers, but right now, you're going to be receiving a lot of information from hospitals about patients who were admitted or discharged. Right now, there's no requirement on you to do anything back the other way, but I can tell you that that's just right now. Things are going to change.
So Lou, I think you're getting into the next slide. Should we go to the next slide perhaps? I think you've covered like the beginning, and now we want to talk about technology and data sharing a little bit. Dan,
Okay.
I don't know if you want to weigh in on this as well.
Yeah, a little bit. And Lou, as we go through it from a hospital viewpoint, Lou's right. There's a tremendous amount of information that under the transparency regulations and under the interoperability requirements that both hospitals and physician providers and others have to follow. There's just a lot of information that's going to start flowing. And April 1 is when hospitals were required to start sending admission, discharge, transfer information to a patient's primary care physician. So as we go through this, keep in mind that if you haven't seen information coming from a hospital about your practice's patients, get ready, because the primary care physician is going to get, if they come in for gallbladder surgery, the primary care physician is going to get a notice that they're in for a gallbladder, whether he knows about it or not. So those are things to think about as Lou goes through this next piece.
And how does that data come across? How do we get that data if we're in a PCP office? How does that show up on our doorstep?
Yeah, there's different platforms that go out, but secure messaging, I guess, is the overall kind of description. And in the state of Florida, we've had to participate in Medicaid has required us to have what they call an event notification system. That's a very narrow network of providers. When the federal government stepped in this year, then we have to go out to every time a patient gives us a primary care physician, whether they're up in Wisconsin or Michigan or New York, Canada, I guess even, but we have our systems have a secure messaging that goes out like an email, and it says, okay, doctor, you have a message coming in from DeSoto Memorial Hospital. I think in our subject line, we probably have, it's one of your patients or something of that nature. And then they have to set up basically a username, password to get into that secure messaging. So it's a little bit stilted, but it doesn't take a lot of time, and a lot of places are going to that kind of a system. So those are right now is the main way to do that. Now the local doctors, they're hooked into our system. So if they got a patient comes over, they can hook in, look at that patient, see their medical record, and go on with life. For the ones that are up north, they're not hooked in, and so they would just have to go with the messaging and then contact us verbally at this point in time. And as Lou will probably tell you, in the future, it probably will become a untouched by human hands kind of correspondence. So we're just in the infancy of this data communication about a patient.
I know we're beginning to hear about that in the MIPS PI, we call it the PI module, where they're mandating and they're scoring providers on data that's being transmitted to and from other providers, and in particular your HIE. And they're talking about having a bidirectional feed, not only taking that data in, but eventually being able to push it back out as well.
And over the years, the big push has been really the communication between the doctors. So if you're an oncologist and you have a patient receiving, the infusions and different things, radiation, How do you keep all the other doctors that's associated with that patient, especially in the Medicare age? Sometimes you have 3 or 4 or 5 doctors. So how do you keep everybody in the loop? And then it's TMI, too much information. And a lot of doctors are going to go, I know they're over there. I don't need to know all that information. Let the oncologist let me know the critical aspects. So, we've battled that with the electronic health record for decades, probably 40, 50 years. And so we're still going to, try to figure out how do we get a smooth operation that doesn't overwhelm everybody. But I guess maybe that's where the big computers come in, the Watsons of the world. But I think we're seeing the tip of the iceberg as Lou goes through this.
Yeah, that's what Dan's saying is very, very true. And what you said as well, Lauren, the fact about MIPS, with the 4 categories, you could see that everything is being touched here, and not only the systems, but the geographic locations that a patient goes to, or whether they have service in an office or an ambulatory surgical center or a hospital. One of the 4 categories, so the MIPS is made up of 4 categories, and one is quality, one is promoting interoperability, as Lauren was saying, PI, one is improvement activities, and the last one is cost. And you don't hear much about cost because CMS really doesn't allow us to choose measures. They look at administrative claims in the background, but Lauren is very deep into this particular topic. If you look at some of the cost measures that CMS is looking at, some of them relate to hospitals. So there's one called an all-cause readmission, and that's important to a hospital to avoid a 30-day readmission because that's a real key indicator to them. Yet it's being looked at on how well a provider who may do work at a hospital will affect all the tax ID numbers that that person interacts with. So MIPS is sort of a microcosm of the bigger everything picture. And that's why, we have the hospital here and me. Can I mention something on the next slide? The CCDA, I saw it go by real fast. The electronic health record in electronic form is called the Compound Document Architecture Clinical Document. That's being broken up into parts in a new system called FHIR, F-H-I-R. So you could pull the parts that Dan was talking about and send them to the person who only needs that one part. So I want to make sure that was mentioned. Go ahead, Lauren.
Thank you. Yeah, so I think Mike has moved us on to you were talking about quality a little bit within MIPS. We certainly have our perspective of what quality means. But I think that when CMS and HHS talk about quality, they're really looking at it on a bigger scale. So what we're doing in MIPS, for one part, they are decreasing the quality component of MIPS and really saying, well, let's talk about quality on a bigger scale. And so I think that Lou and Dan have kind of put together a list of all of the things that CMS considers being part of that quality.
Mm-hmm. Yes, there has been some projects that CMS is running that look at how well your governance runs. We're talking about agencies getting together. There's also the Office of the Inspector General of HHS, and they're looking to see how clean and how up-to-date your policies and procedures are, especially when there's a merger or something between large institutions or even private practices going into an ACO. If you've got policies that don't match up with both entities, something could fall. And as all of you know, or those of you who have reported MIPS in the past, you can't go forward with that PI category unless you click the box that said you did a security risk assessment. So all of a sudden, security is part of quality. So compliance. I saw something the other day where the Office of the Inspector General is starting to audit doctors because they can't find the correct email. This ties over into the commercial side, Medicare Advantage plans, the correct email and address in the NPIS system, NPPES or NPES. If that is incorrect, it's another new rule that if a doctor is listed with a Medicare Advantage plan, their correct address and phone number and email has to be there. And if it's wrong, that could be a mark against the Medicare Advantage plan. So those are commercial payers, the Uniteds, the Aetnas, and the commercial plans work. For those of you who don't know, the commercial plans work with CMS to offer a Medicare-like service, like an HMO. And the way they get paid is they get the money that typically would have gone from the patient to the government, or rather, so the government's giving me, what is it, Dan, about $110 a month for my Medicare, right, or some number. And what they're doing now is they're giving that money over to the United or whoever and that's where the Medicare Advantage plans come from. And then finally, your electronic health record. It's not just having an EHR, it's got to be compliant with what they call 2015 certification. And 2015 can't last forever, so I'm sure that's going to go up a year or so soon. But that 2015 certification is important because it allows, in some of the objectives in MIPS and PI, it allows what they call the referral loop. So from one doctor to another, there's more interoperability. When one doctor refers to another doctor and that doctor, says, yes, I got the referral, that's called closing a referral loop. And that's actually a metric used in PI. So you can see that quality, it's been around for years. When I first started seeing that, how many different hospital programs, Dan, had the word quality in them 5 years ago, 6 years ago?
Yeah, it's quite a few. And actually, Lou, if you go back, a lot of the PHOs, a lot of commercials had a lot of this quality in there and the metrics, and just from the physician side, in our case, we have some CRNAs that don't have office practices, but the metrics revolve around an office practice. So how do you come up with something that qualifies? And they are starting to audit quite a bit. And so all this interoperability, how do you communicate? And they're pushing hard on hospitals anyway to do this provider to provider information. So right now we just share with the primary care physician, but they're also expecting that primary care physician to be talking to the specialists like surgery or other nephrology or other things that dialysis is going on. And how do you, and we've always had this in our EDI world, Lou, that how do you take this vast amount of information that those of us that have been using computers for 50 years have had, and then what do you do with it? And what do you do with the stuff that you don't need? And so storage has become a lot cheaper, and you got the Watson kind of machines now. So this overload of information can now be handled through software. And I guess it's like anything else, it's really hard to keep up with anything without some kind of technology to help. And that's, again, the tip of the iceberg is I think the physician offices are going to get hammered here in the next 5 years because they've been sort of left alone with the hospitals and some of the folks with those big computers going down that road. But we talked a little bit about telehealth. That's been around for 30, 40 years. All of this other information flow has been around, and now it's starting to get more efficient. So they want the providers now to be in the population health management, obviously, that we're on this together kind of thing. And I think that's part of that interoperability. One of the things that, Lou, that physician practices really need to pay attention to, because like ONC and the auditors, Medicare, they're starting to audit hospitals down the micro level of information.
Right, so and it's also, I'm sorry.
I was going to say, let's keep going, and I think we have a slide about that as well. But I wanted I want to make sure we get through with this information because you guys have a lot of good points to make. So here, I think that what we're talking about is we've got all of these different quality programs that really run the spectrum, and a lot of them align. A lot of them are very similar. So I'd kind of like some commentary on that from you.
I guess, Lou, this is more up my alley. That is, the the use of electronic systems has been pushed by Medicare since basically about the turn of the century, where they started putting penalties on, and then meaningful use came piggybacked on that, and now interoperability. So as you can see, there's different penalties and different incentives that we can have some major hits on our reimbursement for Medicare. And I've seen physicians that also have gone through this. If they don't meet some of those quality criteria, Medicare will come in and do sort of the same thing and take 3, 4, 5% back from the physician. So just be aware of that as you go through these pieces. But as you see here, the hospitals have a penalty. And like I tell Lou all the time, a hospital does nothing without a physician order. And I know physicians, we bug the heck out of you for the right diagnosis and this, that, and the other. So these are some of the reasons, besides just good quality patient care, having the right information to treat the patient, that you see some of that push coming from hospitals.
Yeah, I mean, when I look at these, they look really similar to where we're going with MIPS. And I think that with MIPS,
Exactly.
we haven't done as much on the downside, but I think that hospitals have a lot more experience with that. And it's just coming to fruition.
Been out there, yeah. CQM's been out there a long time, and physicians, when you look at, and I've looked at, the ones I have to look at, some make sense, some don't, and we fought those for a long time. But you're on the hospital side, we do the same thing. We go, do they really know what they're looking for? Because the quality measures that we provide sometimes are not quality from an operational side, and so who knows what they use all this information for.
Yeah, we hear that all the time from people. Go ahead, Lou.
It's reputational as well. Hospitals have been compared for many years under, it actually used to be, now it's, I don't know, I think it's their own agency now, but it used to be part of AHRQ, which is now under National Institute of Health. But Hospital Compare was a system where, how well a hospital did. If you're going to go into a hospital, you could look at Hospital Compare and see, who does the best care and who does the worst care and what specialties. So you're seeing again that was almost, the hospitals like a test for the Part B physicians. So now you're seeing Physician Compare. So that's one of the messages that I hope toward the end of this we could get through, is that having a good interaction with these systems helps your reputation. And your reputation, if you want to join a certain ACO group, or if an ACO or some kind of advanced payment, I forgot what the M stands for, APM, if they want to bring you on, they're going to look at, one of the things they're going to look at with physicians is how well did you do in these programs? Whether or not there were exceptions during the year or not, you still are going to be looked at. That there's going to be something that's going to help them gauge whether to invite you into that kind of a group.
So on the screen here, Lou, I don't know if you can see it or not, but I pulled an example from my area where one doctor has performance information and another doesn't. I did read a study in, I think, Health Affairs that talked about how a patient will pay like an extra $4,000 to have a provider that has an extra star on their rating do their surgery. So I think it does result in tangible dollars to the bottom line if you have those performance ratings and make sure that they're good as well.
Those four ratings were
you've got HCAHPS and CHAPS and all that stuff. And you're right, those commercial plans do use those rating systems either to allow you in the network, or they don't allow you in the network, or you get paid a difference. So if you're a star or A level physician, you do get that extra payment. If you're a C level, you get the bottom of the rung payment, or you're kicked out of the network altogether. Hospitals don't work quite that way, but they have sort of the same pressures.
And that whole star system, I think, that whole star system came from the Medicare Advantage programs, the HMOs, and each one of those stars means a very significant amount of money getting paid to that private insurer who's in the Medicare Advantage program. So if they go from 4 stars to 3, they lose a lot of money, a lot of money.
So it sounds like we're going to start here seeing more and more of that from the provider standpoint. I mean, I think that what we report to CMS from a MIPS perspective is just now starting to show up on the Care Compare site. And they're starting to make inroads with that. Up till now, it hasn't been very clear. It's been a little bit fuzzy, but I think it's really coming to bear.
It is. Well, you know, the whole adaptation of the HCAPS to the CAPS system, right? HCAPS was the hospitals. How well, you know, were you happy with your hospital stay? And now all of a sudden, you know, CAPS was there, but it wasn't really used. We're, as a MIPS registry, you know that, well, in the old days, we were allowed to report on CAPS measures, and I think they're coming back again. But right now, you could tell me on that one, Lauren, I believe only a CAPS surveyor can report those measures now.
Correct.
Or can you? Yeah.
No, you have to be certified for that, and it's a whole process. You have to have people that make phone calls in private arenas, and so we chose not to do that.
Yeah.
Can you talk a little bit about price transparency and how that's coming to bear on providers and hospitals?
Well, that's I'm going to defer a lot of that to Dan, but I just want to introduce it this way. It was last week I said to Dan, I was just thinking about, you know, if a hospital today did not take part in programs and an exact duplicate hospital took part in all the programs, would there be a difference? Can the hospital who didn't take part in the programs and join later, can they just do catch up? And the answer is no. If you look at the numbers, and I pulled the numbers, there's more and more of a proportion of revenue coming from taking part in the programs, and compared to the amount of revenue coming from claims and patients being served and what the payer pays. And so, you know, that tells me right there that these programs are critical for revenue because they're part of what the market basket looks like as well. But Dan, you're the CFO there, and I said there, my mentor, Dan's answer. And I asked him this saying, you know, hospitals have to report price transparency. Why would a doctor care? Will a doctor ever have to worry about that? And his answer was great. So go ahead, Dan.
Yeah, you know, there's been a long road on the transparency. It's been out there for many decades of how do you answer the headlines of these large gross charges and what is you know, the Medicare or Blue Cross or commercial payers pay. So as we've gone along with the legislation, you can see from this slide, just this year in Florida, we've had to put the information out in other prior years, but Medicare's clamped down this year. It's got to be a machine readable file, and it includes all of our negotiated rates. There's only one state I know of in the country that has public access to a hospital and a payer's contract. That's West Virginia. And when I was up there, I don't remember anybody ever asking that in public forum, but it is now available. We'll see how many people actually get into it. But there's some consultants that can go into every hospital that's got it up, and the feds are auditing every hospital if you don't have it up in machine readable file, and you have to have every one of your contracts in detail of what they pay you and for what. So you can imagine Blue Cross can look at hospitals, pull that information in and see what United's paying, and then go back to that hospital and say, well, wait a minute, you know, you're paying the other guy way too much more than we are. So from a physician side, you know, I don't think that's required. In Florida, they have to have 15 square feet of a sign in the lobby of their, I think, top 50 procedures or services. And that's been out there for quite a while in Florida. And that's, when I moved down here, that's sort of a shock. But so anyway, it's those kind of things that price transparency is leading down. In the past, there was gross charges, which we all know are meaningless. And from a patient side, they just want to know what their out-of-pocket is. But with these new requirements, if you go out, we have estimators, and if you're a Blue Cross, you can go into your plan and see what it is. My understanding is anybody can go into a Blue Cross portal and get and see what they pay the hospital, but I'm not sure if they're set up quite that way yet or not. So from a physician side, your patients are going to come in if you're doing a gallbladder or something like that, where you have procedures, radiology, CT scan, MRI, mammo, whatever. They may ask and say, well, which hospital was the cheapest and best quality and all those things. So these are portals to get that kind of information. It's not hard to get from any one hospital, but if you're going to compare 3 or 4 hospitals, you got to know the sort of the CPT code and some of that information, which doctors are going to have to help the patient. Now, next year, January 1 of 2022, the commercial payers are going to have to also have this same information available to their members. And so a member can call Blue Cross or United up and say, I want 10 hospitals in my area. What's the cost and what's my out-of-pocket and what's the quality, and on and on and on. And obviously included in there is going to be, well, what doctors are in that network. So there's a lot to this slide that you just need to pay attention to and be aware. It's next couple of years, it is going to be, I think, required of the physicians and other providers.
Well, that sort of leads us to the next point, which is, not only is it that you have to post your costs, but then certainly all of the plans are looking at those costs and picking and choosing who's going to be in their network. So I think, based on cost and quality, that's really making an impact in terms of where your business goes.
Right. We've talked about the STAR system. I don't know which commercial plans, how they decide. You have the ACOs, and they measure the quality of their participating physicians. So as you have on this slide, if you're an in-network provider, theoretically, if there's managed care in that network, again, we go back to that interoperability, it should lower the costs all the way around. It may not lower the cost as the patient sees it from just their billfold, but the overall cost should come down. If, as the slide says, if you're out of network and you're not connected with the other providers, and it takes a village. When you look at some people are fortunate, they only go to the doctor maybe once a year, maybe they only go once every 10 years. But if you have anything serious or chronic conditions, obviously there's more providers become involved, and hospitals only see a patient once in a while. The doctors see them more often. The drugstores see them all the time. And so how do you get all that to come together and make under the population health management, how do you make that a better health for each individual? And that's where a lot of this stuff is going, I think, and it's tough. It's because the carriers are going to come back to the providers and go, like Lou said, why aren't you an A-rated provider? Why do you have these issues, or why does it take so long for your patient to get taken care of?
Yeah, one of the observations, don't forget, I came from the New York healthcare system to Florida. And one of the observations, I said, well, so many, especially now with a lot of New Yorkers and people in Michigan coming to Florida. But in the older days, we call them, the migrating winter residents. We have another word for them, but people will come down here and spend a lot of time, something like 20% of the Florida population goes up while they're here, and they need health care. So, Dan is very familiar with that with his hospital. And being a New Yorker, and I was pretty close to the people in the New York HIEs, and they shared with me, they said, well, when patients come to Florida and they get sick, and it's not minor, what do the doctors work out a referral network with doctors in Florida? And the answer was no. Most of the time they say to the patient, just come back to New York. And so we're finding now with the pandemic, with the telemedicine breakdown of barriers, that New York doctor or whatever doctor can now have a team consult with the Florida doctor or the Michigan doctor, because now there's a loosening on the cross-boundary licensing and credentialing. So all of a sudden, you know, the New York doctor can now see their patients while they're in Florida with Florida doctors. And so I think that that's an important point on the interoperability, doctor interoperability.
Yeah,
And
I think that's a great point.
Yeah.
And Lou, one of the things that Medicare is pushing hospitals is acute care in the home. And that one we cannot figure out. So I'm just envisioning home health. The physician can go to the home now and get paid by Medicare. And now you got the hospital people coming in. There's not going to be enough room in some of these homes to take all these providers at one time. So we're going to have to schedule ourselves so we don't, you know, so we can park on the street instead of double parking. So that's, we may go there one of these days.
Yeah, well, Montefiore Hospital up in New York created an entire building called the Hospital Without Walls. They have no patient rooms. Everyone's at home. That's where their patient rooms are. So, great. Would you like me to address some of this?
So it's not just the hospital journey to the office, it's the hospital journey to the office, to the home health care.
And then back to the office and then back somewhere else. And then, yeah, it can get real crazy when you put a schematic to it.
So I know documentation is a huge issue for a lot of our providers. It's like they know they do it and maybe they even document it, but it's not documented in a place where it gets picked up from an interoperability standpoint. So can you talk a little bit about the impact of that and maybe some of the strategies that have been employed to negate the negative impact of some of this?
Want me to start with that one, Dan, a little bit, and turn it over to you?
And Lou, I don't know.
Well, we were a demonstration project for CMS called the Electronic Medical Documentation Interoperability Project. And we actually showed to CMS, it was about a 2 or 3 year project, where we showed a patient going to a clinic, and then that clinic sees something they don't like, so they'll ask for a blood test at the hospital at DeSoto. The blood test may show something up in the microbiology department, and then that person gets admitted. Someday that person gets discharged. They have to go through DME. Then they go through, if there happen to be a snowbird or they have to be a winter resident, and they go through all these different providers. Maybe they get physical therapy, maybe they get psychiatric help or something. All these providers in that chain, and then toward the end, do they get home health? Do they go into skilled nursing? We had to show that we could track across all systems. Some had no systems either, where we had to put them in. So you had disparate systems, disparate organizations. But the only thing that was in common was it was the same patient. And we needed to track the signatures. In Florida, they had something, what is the Marigold form, and the Florida only accepts a signed, physically signed form. So we had to deal with all of that in the project, and CMS is looking very closely at that. Now, I had some discussions with Dan about the coding and how do you get this, how do you get doctors to, some doctors, well, I don't want to go there, but SNOMED, I wanted Dan's solution to, or one of the potential solutions to documentation is the SNOMED, or Dan, because that's something you taught me.
Well, that's the documentation on this slide. The main point there is to be familiar with the different languages. And I believe right now in the hospital, just for Medicare, we have 7 different languages. SNOMED is standard nomenclature of medical terms, and it's been out there since the early 70s. Pharmacy has the NDCs. Radiology and lab have a thing called LOINC, which is also a standardization of all the tests. And if you look at how a lab test is done or a pharmaceutical, how many aspirins out there, it's unbelievable the number of, they're like SKUs on inventory. How do you keep track of all those things? How do you know which vendor, what their lot number was on our vaccines going out? That, how do we keep track of those lot numbers? So all of these languages in one way or the other, I'm going to put it under a structured language concept. And we've preached that ever since this interoperability started 10 years ago. You really have to understand some of those languages, make sure you've got it in your systems. And if you don't, at least understand where these things can take you, because that's how at least Medicare right now, that's how they track all of these different things like Lou just talked about. And as you move from one specialty to another or one modality to another, that's why the standard languages are there. So that was our point we wanted to make on this. Of course, Lou's got ACO pathways and SMART on there, which are a different form, but they're the same. How do you report all this? How do you measure it? And then what do you do with it? I'm still trying to figure out what they're doing with ICD-10. So maybe one of you tell me.
So how does MIPS fit into this picture?
Hopefully, the thing I think is at the tip of the iceberg, isn't it, Lou?
Yeah.
MIPS, like I said, at least from a hospital standpoint, is we can't do anything without a doctor's order and correspondence with them. And so we just have to be knowledgeable of what each other's requirements are. We have to be, hospitals have to know what the providers need to do to meet their regulations. They don't need to know all the hospitals, but they need to at least know these basics and understand why we're going through all of this.
Yeah. Yeah, it's been the theme of this discussion, is that MIPS is sort of a microcosm of the bigger picture, and you know, understanding it all. Whether you have to, don't get caught up on the. One of my messages would be, don't get caught up on thinking of quality as I've got to pick one of these 6 measures and I've got to have this denominator correct, because CMS is looking at quality in a much bigger fashion. So that's one thing I wanted to make sure of. And interoperability, don't just think of it like the promoting interoperability objective that says you have to close a referral loop. It's all the things we've been talking about. And everything that's going on, don't forget, CMS sees all the claims. So they do see what's going on. And another thing, I don't want to leave the audience, or the people watching rather, you know, we're talking penalty, audits. This is not, I don't want this to be a fear thing. This should really be a positive thing. This is, you know, there are big incentives that you could get by taking part in this that will help you learn where all your payers are going. So if you depend on the payer world to help you, you may have some self-pay. I don't know what your payer mix is. In Florida, we have some people, some doctors who do not take any insurance at all, but they still come to me and they want to know, you know, if there's ways that they could take the words of their diagnoses on a patient and translate them into what would be a specification if it was. So this is a very, in my view, I don't want to concentrate on just you have to do this or you're going to get a penalty. I think doing this is good because the healthcare system, the interaction of the healthcare system, the demographics of the baby boomers, more and more of us getting into chronic care situations, our children, our families. It's a whole team approach, and the best healthcare comes out of a team approach. And so that's where I think interoperability is very important, and quality.
And Lou, I'd say just your last comment there that about CMS, they usually are front running on how things are going to be done by the commercial. And the other side is the speed of technology. And I think we're in the perfect storm where technology and the regulations and just health care, but especially with COVID now, is going to bring a lot of those things together. I view next 5 years, we're probably going to do more in the next 5 years than we've done in the last 30 or 40 years. So we'll see.
Yeah, I agree with that. So.
Well, thank you all for attending, and I want to extend a special thanks to Lou and Dan for being part of this webinar. Like I said, I think that it's great for us to broaden our vision and look at what's going on in other programs and other environments, and see what we can learn from those. So at this point, I guess I'm going to ask Mike if there's any questions. If not, there is more information available. You can reach out to us. We're open to discussion and would love to talk to you.
So there were a couple questions, but you got to them basically as they were being asked. So we appreciate everybody joining us today. You will receive these slides as well as a video of the presentation shortly this afternoon. And if you have any questions, please feel free to reach out to us here.
Mike, let me have one last shot at.
Oh, yeah, go for it. Pardon shot.
The audience is that this stuff is so overwhelming. Just trying to keep up with it. Don't try to do it on your own unless you're really, down deep into the weeds and your experience and knowledge of the different regulations, because it's sort of like the last straw on the camel's back. And that I always keep saying, I think we're getting close to that, but I think the technology and all these other things are going to come along. But if you don't have a good background in it, find somebody that does, the consultants, other of your peers, associations. Lauren can probably help you as guide through as if you got some, what the heck do I do next? And Lou and I just sort of pick it up our experience, but I can't tell you how many things I've missed in the last year, and you go, how did I miss that? So even with consultants, and so that's sort of be my last word is just don't do it on your own.
Great. Thanks, Dan. Really appreciate that. So if you guys have any other questions, you could shoot them to us or put them in the question box right now, and we'll have our team panelists reach out to you afterwards with an answer. So everybody have a wonderful day, and we look forward, and thank you very much to Lou, Dan, and Lauren for joining us today. Appreciate it.
Thanks, Dan. Thanks, Lou. I really appreciate it. Thanks, Lou, for bringing us together.
Okay,
It was fun.
you're welcome. Thank you.
Bye-bye.
Bye-bye.
Bye now.